Welcome. I'm Michelle Kalf, Director of Business Development at Rogers Behavioral Health, and I am your moderator for today's webinar, Examining Co-occurring OCD and Depression. Joining me today are Drs. Marty Franklin, Clinical Director of Rogers Philadelphia location, and Dr. Rachel Leonard, Executive Director of Rogers Regional Division. Before we get started, I wanted to give you a quick overview of the format. The webinar is scheduled for 90 minutes. There's no need to check in. To receive CE credits, you must be logged into the webinar for the entire program. A PDF of the PowerPoint slides and a list of references will be available after the program via an email that's sent out, and it will come from ce-go.com. In addition, a recording of the webinar will be published under Resources section of our website within the next few days for you to rewatch. Our speakers will give a 75-minute presentation. Following their presentation, I will facilitate the Q&A session. If you would like to ask our speakers a question during the presentation, please use the Q&A button, not the chat button, to send me a message. At the bottom of your screen, you simply click on the Q&A button on the Zoom taskbar. I will review the questions submitted, then the presenters will address them during the Q&A portion of the webinar. Now I'll turn it over to our presenters.
Hi everyone, welcome. We're excited to be here and wanted to start by just sharing that neither of us has anything to disclose. These are the learning objectives that we have for today. And then here's an overview of what we'll be discussing. We will start by reviewing co-occurring OCD and major depressive disorder, then move on to assessing for risk of suicide and non-suicidal self-injury, and then finally discuss kind of that tricky differentiation between intrusive OCD thoughts about suicide or non-suicidal self-injury, and distinguishing that from non-OCD related suicidal ideation. We'll conclude with a case example before moving on to the Q&A section. So to start, co-occurring OCD and major depressive disorder.
All right, so good afternoon, everyone. And I'm going to talk a little bit first about the diagnostic criteria for OCD. Just hitting some of the highlights. I won't read this to you. But obsessions are intrusive thoughts or images that the person experiences as unwanted. Very important, and that helps us with this distinction later. And the occurrence of those causes anxiety or distress or discomfort. People describe it in different ways. And then that because of that negative emotion comes, people make some efforts to ignore or suppress the thoughts. Those efforts are often in the form of compulsion. So repetitive behaviors or mental acts performed that are designed purposely to reduce the likelihood of feared outcomes or to reduce anxiety or both. And then I think the issue of it being excessive or not logically connected to feared event. If I have a bad thought and I have to do some tapping to make that bad thought not occur or make the feared outcome not occur, then that's a good example of where there's no logical connection between me tapping a desk and my mother not getting in a car accident. So that's a good example of how those things might play out. So obsessions give rise to anxiety, compulsions reduce it, and that functional connection between obsession and compulsion is really where the action of the treatment will come. We'll talk about that in a bit. Okay, next one. So there are subtypes or dimensions of OCD symptoms. Most common one is contamination with associated cleaning and washing rituals. It's sort of your quintessential OCD symptom, but the reality is there are lots and lots of others. And so I don't want to restrict myself to just contamination, fear, and associated hand washing. The pandemic has made this an interesting differential. because we're being reminded periodically to go and wash our hands when we come in from outside, etc. One thing I remind people of, though, is that Dr. Fauci has not recommended washing your hands 65 times or taking a 2-hour shower. He has a 20-second hand wash, and then you're good to go. Once you're in your own house, you're in a private setting, you don't need to be repeating that hand wash or checking to make sure you did it perfectly, etc. We cross over from reasonable care in the context of a pandemic into compulsion, depending on the function of that behavior and also depending on its intensity, severity. So we certainly have people who are also worried about causing harm, making mistakes. A lot of times the associated compulsion there is checking. So making sure they didn't cause harm, making sure they didn't make mistakes. So if I do a paper and then I'm ready to submit it and I start to check it repeatedly to make sure I didn't put anything awful in there, or trying to make sure that it's perfect, and maybe I spend so much time on that editing process that I don't even submit the paper. And that would be a sign that we're gone from editing, which is a good thing, to checking and doing compulsions, which is not such a good thing. Responsibility for causing harm to others. Certainly those of us who do a lot of this work have seen the presentation where a person is driving the car, they hit a bump, and they might worry that they hit a person, and they may go back and check, circle back their route. I've certainly had patients who will call the police and announce accidents that didn't happen. And when you're getting to that level of severity, you may be talking about clinical OCD. Symmetry and order, things having to be in a certain way, and then ordering and arranging is the associated compulsion there. We certainly have a lot of people who have unacceptable thoughts, intrusive, sexual, religious content, scrupulosity, aggressive thought, like if sitting next to somebody at work and I'm holding my pen, how do I know? So what if I just took my pen and shoved it into my colleague's eye? And then I get the unwanted anxiety with that. My ritual might be replacing that bad thought with a good thought. I might put my pen down, I might leave the situation, but there's this sort of connection between the obsession and the compulsion that's really important. So the obsessions give rise to anxiety, the compulsions reduce it, and the problem, of course, is that when it's reduced by compulsion, the next time it happens, I'm going to want to do it again. So if I touch my desk and fear it's sticky and contaminated, and I go wash my hands, the next time I touch something I fear is sticky or contaminated, I'm going to want to wash my hands. I get back on that same treadmill. And usually people have more than one obsessional theme. You might see 3 or 4, but there's usually a primary one. The way I talk about it is OCD is like the state of Hawaii, in that there's a big island and there's a couple of smaller ones, and all of them can be organized hierarchically to help us with the treatment, which we'll chat about in a bit. Okay?
So then switching over, here are the criteria for major depressive disorder. I think a lot of people are quite familiar with this. This is something we see very often. The highlights here are that, this is kind of a rare disorder where you need to have one of 2 core symptoms and then can add a smattering of others. So there needs to be either depressed mood most of the day, nearly every day, or a loss of interest or pleasure in most activities. Often we see those both in cases of MDD, especially as the severity is increasing. And then you can see on the side there are the additional symptoms that you could see. One thing that is interesting, I think, about depression is that some of these symptoms are actually opposites. So you could have insomnia or hypersomnia, weight loss or weight gain, increases or decreases in appetite. And so I think that can make it challenging at times to recognize major depressive disorder in people. And then added to that is this complication that in adolescents or young adults, sometimes what you see is more irritability, crankiness, kind of anger versus reported sadness. So that can make it a little challenging to recognize as well. One of the symptoms here that we'll be talking more about today is the thoughts of death or suicide and how that relates to the OCD co-occurring within depression as well.
All right. So I think this is certainly worth noting and also thinking about how we can fix. This was the National Survey of American Life. Joe Himley at University of Michigan and colleagues, 2008, did a pretty large survey and basically found comparable base rates across racial and ethnic groups when it came to OCD. So there doesn't look like from the epidemiologic perspective, there are huge group differences here. However, when you look at some of the key studies that have been done, the DSM-4 field trial done in 1995, multi-site study done primarily in major U.S. cities that had pretty large African American populations, and yet across the entire study there were only 2.8% African American participation in the DSM-4 field trial, despite that comparable rate of OCD in all the communities. We also know, this is from Monica Williams' work, that if you look across randomized controlled trials that have been done in North America, looks like about 2%. So the DSM-4 field trial is not unrepresentative, about 2% of African American participation in RCTs, and less than 1% in a Rogers-based study that Williams also did. So to me, if we have folks out there who have this condition and we're not getting them into the field trials, and we're not getting them into the randomized trials, and we're not getting them into the residential treatment settings, we have to start asking ourselves what's going on. And there's a number of considerations here, but I think it's really important as a field, if we start thinking about our treatments being accessible to all people, I think we haven't achieved that yet according to these data, and it's an ongoing issue for us to grapple with as a field, and really as a culture as well. I think it's not specific to the OCD field, certainly. Okay, next one.
And then here's a look at the data for major depressive episodes by race and ethnicity, age, and sex. Here you can see there's some variability, with the highest rates being for those who identify as having two or more races or ethnicities. But again, I think, there's a bit of a mismatch sometimes between that kind of base rate and then treatment seeking. So here, there's been some work that looked at this with depression, similarly to what Dr. Franklin just discussed about OCD. And we see that African Americans and Caribbean Blacks are much less likely to receive treatment. And despite that, they're actually more likely to rate their depression as being severe or very severe when compared to whites. There's been some interesting research looking at different factors that impact depression and the rates by race and ethnicity. Certainly, discrimination makes it more likely that someone will endorse depressive symptoms, whereas having job security or higher SES, being married, and feeling a strong sense of ethnic identity were all protective factors. So I think it will be important to look at that further to see how we can get a better representation in treatment and in the research studies as well. So, thinking about both OCD and depression together, I think on the surface, they may seem pretty different from one another. But really, for both of them, avoidance is kind of the central, one of the hallmark features. And so there's avoidance of many different types of activities. With OCD, there's significant avoidance of obsessional triggers. And in depression, there's avoidance of often social interaction, of a sense of pressure or responsibility, sometimes of just leaving the home. And there's often these problematic mental processes in both OCD and depression as well. With OCD, that might be these mental rituals that Dr. Franklin discussed. It might be kind of reviewing past activities for proof that one of their fears is true. With depression, you see a lot of depressive rumination. So thinking over and over about negative events that have happened to them, about the circumstances of their depression. Why me? This is never going to get better. And it's kind of this cyclical process that isn't necessarily very productive. And then the other similarity between OCD and depression is that typically as time progresses, the individual's world will shrink. And so the more they avoid, the more that might be kind of negatively reinforced, but then they find themselves with fewer and fewer things that they can do that bring joy to their life. So research on the co-occurrence of both of these things show that that's happening pretty often. So about 63% of people with OCD have met criteria for depressive or bipolar disorder during their lifetime. And within OCD, MDD is the most common mood disorder that we tend to see. Maybe it's the levels of care in which I work, but I feel like that 63% is a low estimate. Seems pretty common when treating OCD that there's some mood symptoms present as well.
So a question that arises, and you'll have to grapple with clinically, is which of these things comes first? And in general, what we see is the OCD, when you have both, the OCD tends to precede the development of full-on MDD, which is not to say there aren't subclinical depressive symptoms in the midst of the OCD when the OCD is on a full clinical severity. But the disorder of depression tends to onset after the disorder of OCD. A couple of citations for that. It raises lots of interesting questions, which is, okay, so is the major depressive disorder simply a response to the distress and impairment associated with OCD? It's hard, and when you're having clinically significant OCD and associated functional impairment, it's hard not to feel sad. It's hard not to feel restricted. It's hard not to have those negative symptoms because your world's getting smaller, and it's probably not so hard to notice that. And if you're trying to avoid OCD, you're doing it at some cost, and oftentimes that cost is of things that you enjoy. And if we think about major depressive disorder, starting to do less and less of the things you enjoy might be an exacerbating factor. There's probably bidirectionality to that. But you're not engaging in things that you have fun with. You're not engaging with people because people are a trigger. Maybe you have contamination fear and you're isolated. We certainly have seen that. Increased rates in anxiety and depression and OCD over the course of the pandemic, which could be simply the downstream effect of social isolation. So there's lots of complex interactions here. But what I think is really important to recognize is that there's a relationship between this stress and sadness and withdrawal, and probably sadness and withdrawal get worse the more you avoid people. So these complex interactions need to be grappled with. But I'll also say this, even if the OCD onset is first, it doesn't necessarily tell you that I should treat the OCD first. We're going to get to that in a bit. So I have to look at the severity of the depression, even if it's secondary, even if the patient overtly says the reason I'm depressed is because of the impairing effects of my OCD. I still have to look at how severe the depression is, what's associated with it, whether or not they have concomitant suicidality before I make an informed clinical decision as to which I'm going to go after first. So which one comes first doesn't answer that question. It's part of an answer, but it's not the whole answer. We'll get into the whole answer in a minute. So
when to treat the depression, as Dr. Franklin was saying, it's a little bit complicated and it depends on a number of different factors. So it may or may not be necessary actually to treat the depression directly at all. So sometimes if OCD is clearly primary, if there aren't certain features that are part of the depressive symptoms and impacting treatment, we might just start with OCD treatment, monitor mood, and as OCD symptoms improve, you might see those depressive symptoms lift. as a result. So they, the avoidance is decreasing. They're able to engage in the activities that they previously enjoyed without the impact of OCD there. So then their mood lifts. So that's kind of a nice best case scenario. But sometimes we do need more targeted depressive treatment or depression treatment when we're treating the OCD. So some examples here would be if the depression is really impacting the patient's ability to engage fully in OCD treatment. So if they're really struggling with motivation, if they're not showing up to treatment, if they're ruminating and not really participating fully in ERP work, that might be a sign that we should add in some targeted depression treatment. If the OCD symptoms improve, but we don't see kind of a co-occurring improvement in the mood symptoms, that's another sign that maybe something more is needed here to help that patient. And then we might want to, at that point, add in some depression treatment. And if there's significant suicidal ideation or safety concerns that are part of the depressive presentation, then that's something we'd want to take seriously and really go after right away as well. So here we wanted to shift gears a little bit and talk about suicide risk and non-suicidal self-injury as that relates to OCD and depression.
All right, so talk about risk factors for suicide and also for OCD. We certainly have seen in the research realm greater likelihood of having lifetime suicidal ideation for those with OCD compared to the general population. So maybe the rising tide raising all boats, or maybe there's a more specific pathway. And that greater suicide risk is associated with OCD severity, which again, back to what I said before, the more restricted and the smaller your world is, maybe that's going to have even more of an impact on your life and on your enjoyment and restricting your functioning. So you would not be surprised to see those things being connected. So in general, we have that. There's also interesting work that's been done looking at the type of OCD symptoms. And the folks who have the unacceptable thoughts might be especially vulnerable to more severe suicide risk and more severe depressive symptoms as well, which makes some sense because there's some lack of willingness or comfort sharing that. So if I have intrusive thoughts that I might drown my child and they're quintessentially OCD, I may not be so comfortable saying that. And if I find that to be the case, I'm not going to get support around it because people may be restricting their seeking help around such things. And then you wind up in this sort of circle that isn't broken. Comorbidity with other mental disorders, we've certainly seen that. PTSD, substance use disorders, impulse control disorders, all of that comorbidity, that soup, if you will, increases the likelihood of suicidal ideation. And I don't mean suicidal obsessions. We'll get into that distinction in a bit. I mean suicidal ideation, desire to die, and a desire to engage in behaviors to bring that about. That's not the same thing as intrusive images of committing suicide that aren't connected to a desire to die. So we also see that the severity of co-occurring depression and or anxiety symptoms can push that increased risk for suicidality in the context of OCD. Your own history, if I have a history of suicidality, I'm more at risk for having subsequent bouts and increased risk for that. And obviously hopelessness and alexithymia are also risk factors in the context of OCD for having increased suicidal ideation. So how does this play out clinically? I need to do really careful assessment of suicide and suicidal behavior, suicide history, desire to die at admission. It's always recommended with safety planning following this as needed. And what I would say there is if I have somebody who's already demonstrating it at intake that they're contemplating taking their own life or they have a history of attempting to do so, I'm going to need to be really attentive to that, and I'm going to need to start thinking already about methods I'm going to use in order to mitigate that risk. And Rachel will talk you through some of that. What I also say is the treatment of depression may reduce suicide risk in individuals with OCD. I think I saw something in the chat about whether depression is a risk factor for non-response to OCD treatment. And oddly enough, 20 years ago, John Abramowitz and I, when we were at the Center for the Treatment and Study of Anxiety, being mentored by Edna Foe and Michael Kozak, we did a study looking in our own outpatient data for OCD, looking at, first of all, we went and we got a severity measure, the HAM-D, on everybody that came through that. It was 110 people in the trial. And so we looked at depressive symptoms, and indeed, Rachel's estimates are right. About half that sample had a concomitant depression diagnosis and had significant HAM-D scores on average. And then when I look at outcome, when I break out the response to the OCD treatment, these are people who had primary OCD. We did what Rachel had suggested, which is we treated the OCD first. When I look at response rates in that particular study, what we found was the level of severity of depression mattered. In that if your depression was low, if it was moderate, if it was a little bit towards the high side, but not very high, your response to the OCD treatment was not at all attenuated. So you responded as we might expect compared to the non-depressed samples. And what was interesting too is we got about a 50% reduction on the HAM-D pre-post without touching the depression, really. I mean, some of these folks were on antidepressant, and I'd say the majority were on they were on it when they got to us. But they were on one that had also had anti-obsessional properties. So can't be certain for sure about what they were responding to. But on average, they were responding quite well to the OCD treatment, with one exception. And that exception was severe depression. HAM-D scores, I think, over 20. If your HAM-D score was over 20 and you went into the OCD treatment, you did better than pre-post reduction, but not like the rest of the sample, which was an interesting thing to see in the outpatient context. Well, what's interesting is 20 years later, along with Rachel, Chad Wetterneck led this investigation, looking at the very same thing, cutting the data the exact same way that they had cut it originally, or that we had cut it originally, and looking at OCD treatment response in folks at the various levels of depression. What was fascinating about that is the effect of high depression getting in the way of OCD treatment was gone. So when you're treating at a higher level of care, it looked like severe depression wasn't getting in the way. People were responding comparably across those groups. So to me, that becomes a recommendation clinically. If your depression's severe and I'm trying to treat you in the outpatient setting with OCD treatment, it makes me wonder if maybe you need a higher level of care in order to respond effectively or more robustly to the OCD treatment. So it became 20 years apart. I actually think it was helpful to do, and now gives us more specificity with respect to what we would expect. So depression could get in the way. The data would suggest that it only might in the outpatient setting. It's more likely to if you have severe depression. The rest of it seems to be, and again, back to what I was saying before, if your OCD is the cause of depression, quote unquote, meaning you're sad and you're feeling upset and lonely and isolated and don't feel like doing things that are fun because your OCD's in the way. If I get the OCD out of your way, I may see some improvements there. And indeed, that is what we see. So I think long and the short of it is it may be helpful to focus on the ERP and see what I'm getting with depression. Unless I've got enough depression already, I can make a reliable prediction that maybe I should be doing that instead. So I think that we want to pay attention to that, and especially if you've got the unacceptable thought dimension of OCD, I'm going to need to pay attention to this complex interaction between the OCD and intrusive thoughts about suicide, which is certainly not an uncommon presentation, but also ego-syntonic and not intrusive thoughts about suicide that are connected to hopelessness, depression, and distress. We're going to get into that fine-grained analysis as we go. But we already know that if unacceptable thought OCD is a risk factor for increased depression, which in turn is a risk factor for suicidality, up front, I know at intake, I know that's the primary problem. I'm going to already need to start planning and thinking about what am I going to do about the suicidality? What am I going to do about the depression in the context of trying to treat this unacceptable thought stuff? I have intrusive thoughts about shoving people in front of the subway train as it arrives. I may well be more vulnerable to these other things, and I need to pay some attention to how that plays out and what I should be focusing on in treatment as we go. Okay, next one.
So here we'll talk about one method of assessing suicide risk. It's certainly not the only option. There's a number of good ways of doing this that have support. So there's, the CAMS is another one that many people are familiar with. This is the safety risk assessment that includes the Columbia within it. And this is something that is kind of straightforward and easy to use. They have a very helpful website. The link is below on this slide with a number of kind of different versions of this for different settings. So check that out if you're interested. But this is really a process to guide you through how to complete a thorough suicide assessment. And it includes identifying both modifiable and non-modifiable risk factors. So we certainly want to know what the non-modifiable risk factors might be for a certain person. So if it's an older white male, I'm automatically going to be a little more concerned because that's a higher risk kind of demographic. But then with the modifiable risk factors, those are really helpful to identify because they could be modified. So then over the course of treatment, those are things we really might want to hone in on and try to change over the course of time. We also want to identify protective factors. So is this person, is their religious beliefs such that they would never, consider suicide despite how depressed or hopeless they may feel? Or do they have family obligations or hobbies or other things they identify as really being a deterrent for them in ever attempting suicide? And getting that strength rating will help you know kind of which order to place them in. And then that's another option for you over the course of treatment. So if their relationship with their grandson is their highest protective factor, how can we remind them of that? How can we place those reminders in important places so that if they are struggling, they come into contact with that and then really use that as a way to keep that patient safe. We, of course, want to assess for suicidal thoughts, any plans they have, behaviors they've had in the past. If they've had a suicide attempt in the past, that's, of course, a risk factor for suicidal behavior again in the future. And then degree of intent they have currently. And this is where the Columbia or the CSSRS can be very helpful in kind of going through in a really structured way to identify risk. That can then lead you to a risk determination or a level of risk, which might help choose kind of those next steps and interventions needed. So certainly, inpatient hospitalization, sending a patient to the ER, that can be very helpful. If there does seem to be really kind of immediate risk and intent, but otherwise, this can all be helpful in the safety planning process as well. One of the things that can be challenging, though, is that when we have patients who have both depression and OCD, and we're trying to assess suicide risk, it may be challenging to get a really clear sense from the patient because of the doubt associated with their OCD symptoms. So if they do have thoughts that are kind of OCD in nature about suicide, if they have those obsessions, then they may really struggle to identify if they do or do not have intent. There might be some doubt there. And at times too, there might be this distinction to be made between true suicidal behavior that is kind of wanted mood-related, and kind of ego-syntonic, versus some testing behaviors that are done to reassure someone that they actually do or do not want to harm themselves. And so if I have a thought, an intrusive thought about harming myself or about suicide, and I get a knife and I hold it to my wrist to see if I'm going to do anything, and then I don't do something and feel better, that's more consistent with OCD versus really having wanted thoughts about suicide and then kind of thinking through those steps. But it's a fine line and a challenging distinction to make. It's also important to identify if any harm has been done at any point, if there have been true suicide attempts, non-suicidal self-injury, if they've taken preparatory steps. This is a really nice way, I think, to gain some clarity. So have they written a suicide letter? Have they given away possessions? Those kinds of things are certainly red flags. And looking at those risk and protective factors and going back to that history in terms of past suicidal behavior might be a little more clear cut than trying to get a really clear answer about intent. So these are the different risk levels based on the safety with the CSSRS. So high risk would be somebody who is identifying that they're having thoughts about suicide with intent or with plan and intent together, sometime within the past month, or they've engaged in suicidal behavior at some point in the past 3 months. So if you have a patient in this category, that's someone we would definitely recommend engaging in significant safety planning with right off the bat. Also working with family members and taking a number of steps to work to reduce risk. And then moderate and low risk are listed here as well. Moderate might be that there's a method but not a plan. So if you have somebody who's saying, if I ever attempted, it would be via overdose, but they haven't come up with a plan to go to Walgreens and purchase 6 bottles of Tylenol and take that this weekend when their family's away. That's the difference between a method and a plan. With a plan, there's more specificity involved and often a sense of intent that's along with that as well. If they've had suicidal behavior at some point more than 3 months ago, that's also moderate risk. Or if they have a number of risk factors and very few protective factors, that would place them in this category as well. So one of the things that I think is really important to consider is means restriction. And so if you're talking with a patient and they have identified a method or a plan, and especially if that method or plan involves a firearm, this is something that's very important upfront to talk about with your patient and with their family members or an emergency contact as well. The research shows us that even if somebody has kind of chronic suicidality and have been thinking about suicide for a long time, that the period between really active intent and taking steps to attempt suicide is very brief. So this study that looked at 82 individuals who survived a suicide attempt found that almost half of them reported that their first current thought of suicide before attempting was within 10 minutes of their attempt. And so there's a significant degree of impulsivity that's present in a lot of these cases where somebody goes through with an attempt. And so really any barriers in that brief period of time are incredibly helpful. So if we've already had that conversation, if we've removed firearms from the home, or if parents or somebody else, has the thumbprint lock that only they can access, or if we've, restricted access to medications, especially those that could be more risky, that could really be life-saving when that impulsivity hits. So that's an important conversation to have up front. And then, other parts of safety planning, I won't go through this in too much detail. I think this is something a lot of people are fairly familiar with, but talking both with your patient and with their support team, so that could be parents or spouses or friends, about warning signs of distress, that might be helpful for people to recognize that they might need to start intervening, using some distress tolerance skills, reaching out for help. Unsafe behaviors that they might have a tendency to engage in when they are feeling distressed. So are they more likely to have suicidal ideation? Are they more likely to engage in non-suicidal self-injury? And then signs that they're really seriously in trouble and might need some immediate intervention. And then providing phone numbers to those support individuals, to crisis lines, text numbers. I think younger people now are also often uncomfortable calling. And so having those text lines, I think, can be really helpful. And then also identifying a local psychiatric emergency center as well.
Okay, so ways to make these distinctions, because we're talking about suicide, we're talking about suicidality, we're talking about suicidal obsessions, non-suicidal self-injury. I want to get into the weeds here. So we consider these thoughts about suicide to be obsessional if the thoughts are being experienced as intrusive, and the primary affect in response to it is anxiety. Oh my God, I can't believe that thought just occurred. That's horrifying. I would never do such a thing. I need to move away from this. And behavior that is in the wake of that is an intentional effort to neutralize the thoughts, reduce the thoughts, reduce the associated anxieties. I have to think about something else. I have to do something else. I have to do my rituals to prevent these thoughts from continuing, which is a very important distinction, as opposed to elaborating them on purpose because it's mood convergent. The people who are reporting about obsessions related to suicide are not reporting an intent to die. I had no intent whatsoever. I had somebody recently tell me that she was driving over one of our big bridges here in Philadelphia, and she had an intrusive image that she could turn her car to the right. There was a very low barrier, and she could turn her wheel to the right and plunge into the river and die. And she had no intent, she had no desire, she was terrified by it. She actually moved from the right lane to the center lane to put traffic in the way of her doing that, but she had no intent to do it. And a lot of times sometimes it's imagery. I had a person tell me recently that they had intrusive thoughts about, or images of hanging. So they'd see something, they see like a shower curtain, hanging off of a shower in the shower, and they would have intrusive thoughts that they would hang themselves by that curtain. And again, unwanted, intrusive, no intent to go to the bathroom, to do anything like that, wasn't thinking about it before, just had intrusive imagery of that type. And a lot of times we hear the what if language. What if I were to do this? What if I'm going to do this? What would it be like? Why am I having these thoughts? Maybe it means that I want to, as opposed to I know that I want to, and I'm going to follow through on it. So that questioning and the anxiety being primary affect leads me in the direction of these are obsessions, and they just so happen to be obsessions about suicide. Okay, next one. So ideation, in contrast, the intent to die is prominent. I can't take this anymore. I don't want to be around. I can't handle it. My life is a misery, and I'd be better off dead. My family would be better off without me, etc. I want to die. So you hear that there. You did not hear that in what I was saying before. The what ifing. The woman who was driving across the bridge, it was absolutely divergent from her. She said, I was even having a pretty good day, and I just get this thought, and I get worried about why am I having the thought. That's not what we're seeing in ideation. There are direct efforts and planning and thinking about intentionally ending one's own life. That fits under the umbrella of suicidal ideation, not suicidal obsession. The function of that is sometimes to escape negative affect. I'm tired of living this way, and I need this to stop. And I need to stop it now. I think that's what Rachel was saying about that urgency can sometimes be from thought to behavior, can be really fast. When you throw impulsivity on top of that, like teens, sometimes our teens who make suicide attempts don't have a depression diagnosis. but they have an impulsivity problem. So things happen that are miserable and they think, I don't want to live like this anymore. And then they act quickly on that negative affect. The perception of burdensomeness is also prominent in the context of suicidal ideation, the idea of thwarted belonging. This is from Joyner's work. And also making efforts to not be discovered. Somebody who checks into a hotel in another city in order to end their own life and tells nobody that they're there is pretty serious, which is in contrast sometimes to somebody who's making an attempt and doing so in their own home with everybody around. That may buy you some time, but I also think that intrusive related suicidal obsession sometimes doesn't take any of that into account. You could be having that while sitting in the middle of your living room. What if I did this? Or I'm watching a movie. I think there was a movie recently which I loved, A Star is Born. There's a bunch of suicide related stuff in there, and somebody with OCD might watch that movie and think, oh my God, what if I did that? Somebody with depression, though, might be thinking the same thing and seeing this can prompt their further desire to die and give them some more, push them further along that path. Those are very different things. Okay, next. And we have talked too much about this, but non-suicidal self-injury, which you can sometimes see in the context of depression, and you can sometimes see in the context of other mental health challenges, but direct, deliberate destruction of body tissue in the absence of an intent to die. So I'm cutting, but I'm cutting in order to either relieve myself of affect, or sometimes people will describe it as I feel nothing and I need to feel something. So those are two ways it's described, but there's no intent to die. Moving away from negative affect may be the function of that behavior, and it may be preceded by acute negative affect. I'm tired of this crap. I can't believe this is happening again. I'm going to do some cutting. I'm going to do some burning to make myself feel better or feel different. Change the modality a little bit. And there's some relief experience from doing that. A lot of times there's pain analgesia. We don't know if that's simply a function of having habituated to pain or whether that's something else. And then on occasion, you'll hear people say, well, I had a bad thought or I had an unwanted experience and I should be punished for it. And they punish themselves in this way. Okay, next one. So intrusive thought or not. Differentiating OCD from non-OCD suicidal ideation. And you're going to need to make that distinction either in the absence of comorbidity or in the presence of comorbidity. In the presence of comorbidity, you got to be able to teach your patient to do the same thing in real time. So they're trying the right intervention for the right thing. Okay, next one.
So here are some examples of intrusive thoughts about suicide. As Marty was saying, they're experienced as unwanted, intrusive. They don't want these thoughts to be there. They're bothered by the thoughts. And then they come along with that sense of anxiety, fear, or doubt and uncertainty. So it's more of that questioning, am I going to hurt myself? What if these thoughts mean I want to die? So kind of worry about what the thoughts mean about the presence of those symptoms. And that could be some examples in line with what Marty had shared too. Fear of committing suicide. Sometimes there's that fear of driving off of a bridge, or what if I drive into oncoming traffic on purpose? Fear that as they're taking a walk, they might jump off of a building or off of a bridge. So that sense of kind of that uncertainty and that doubt is generally present. Intrusive thoughts about suicide tend to also then be associated with avoidance. So they might start to avoid walking on that bridge or driving over the bridge or going to the places where they've had these intrusive thoughts occur in the past in an effort to try to keep themselves safe. They might avoid knives or other things in their home. They might start engaging in safety behaviors. So maybe I can still take that nice walk, but only if somebody else is with me and I'm holding their hand. And then certainly having some rituals associated with this as well to decrease the anxiety, doubt, or uncertainty that comes along with these types of intrusive thoughts, or to reduce the chances that they think they will actually do this. So they might refuse to be alone. They might frequently seek reassurance that they're not going to act on these thoughts, that they don't mean anything, that it doesn't mean they're a bad person. They might review in their mind past behaviors to remind themselves that they haven't done this before as a way of giving some self-assurance. Or they might try to mentally neutralize these thoughts. There are so many different things that people might do. So this is just, some examples, but really the point would be that those rituals would be functionally related to the intrusive thoughts in an effort to reduce the anxiety or to reduce the chances that they would actually act on them and that feared outcome would happen. So if we have intrusive thoughts about suicide that match those previous two slides, then the intervention is clearly exposure and response prevention. So we want to expose the patient to those thoughts about suicide that they experience as intrusive and unwanted, decrease their avoidance and safety behaviors gradually over time, so starting to approach being able to walk over that bridge again, and facing those triggers that might lead to the thoughts, while also preventing them from doing any of the rituals, the avoidance that was going along with those intrusive thoughts as well. So allowing that doubt, uncertainty, and anxiety to be there without kind of purposefully trying to get rid of it or decrease it. In contrast, when we have that ego-syntonic suicidal ideation that tends to be mood congruent, people might start to think about the benefits of suicide, how this might be better for the people in their lives, it might end their pain. They may include some associated suicidal behaviors, so they might start writing goodbye notes, they might prepare a will, they might start buying things that they need to act on their plan, like, over-the-counter medications or rope or things like that. They might start writing goodbye notes. And here it's more common that they've had a history of previous suicidal behavior or self-harm or non-suicidal self-injury. And for this case, then the intervention is risk mitigation coupled with distress tolerance skills, in addition to kind of longer-term depression treatment or treating any additional symptoms that they're experiencing that are contributing to that suicidal ideation. So as I mentioned earlier, of course, we always want to consider inpatient hospitalization if that's needed based on the severity of the suicidal ideation. We want to engage in means restriction along with the safety planning we talked about earlier. Here, distress tolerance skills can be really helpful in reducing the distress. And so teaching our patients what those skills are, how to use them, keeping them in a place where they can access them quickly if needed, or having coaching available can be really helpful too. So here a lot of DBT skills can be very useful. Also having reminders of reasons for living and or the protective factors we talked about before. So how can we use that to our advantage to help keep our patients safe and engage them with those protective factors or reasons for living. And making sure we're not only following that safety plan, but we're updating it as needed. And so as your patient learns new skills, maybe they find one that works really well for them, we want to add that to their safety plan. So then I think that really tricky situation happens when you have a patient who has both. So if you have a patient who has OCD symptoms that include intrusive thoughts about suicide, but then they also experience hopelessness and some wanted suicidal thoughts, this can be a really challenging situation to navigate that can feel really risky and uncomfortable, I think, for a lot of providers. And so, of course, we'd start here with that detailed suicide risk assessment and safety planning. And we'd want to see, what is their risk level? If they're high risk, if they have current or recent intent associated with their suicidal thinking, well, then we might want to really hone in first on some of those interventions to target the suicide risk before engaging in specific exposures directly targeted at that. Or we'd at least want to be really careful about how we're doing that. And that's something we can talk about a little bit later too. If the answer is no, if they're not high risk, if they don't have current or recent intent, then we can feel a little more comfortable proceeding in the ERP work, specifically targeting those suicidal or intrusive thoughts about suicide. It can be helpful to get some safety ratings. This can also be tricky, but if we're able to ask some questions to ascertain current risk before proceeding with some exposures that might seem more risky, that could be helpful to do. And then just be thinking about where and when the patient would be doing any of these exposures and what the content of the exposure would be and if you think any risk is involved. So the hierarchy here may be kind of to your advantage, where we would start easier exposures first, while maybe working on hopelessness, depression, and those other factors that might contribute to any true SI thoughts, and then gradually work up to those exposures that might be more challenging and also seem to be a little bit more risky, things that might involve being alone, walking over the bridge, for example. So here we'd also want to prioritize those treatment strategies that reduce the wanted suicidal thoughts closer to the beginning of treatment. So incorporating depression treatment for these patients, bringing in some of those DBT skills can be very helpful. And if they do have specific stressors that they've identified that impact their SI, then really targeting these too. And so sleep difficulties can be a big risk factor for suicidal ideation. And so if that is happening for your patient, really aggressively going after that, going after relationship difficulties, anything that's really contributing to that. And then thinking about the overall makeup of OCD symptoms and which are contributing most to the distress and impairment that they're experiencing, especially if that's kind of linked then to when they're endorsing SI as well.
Okay, so a metaphor I've come up with through a fair amount of driving through the South. And so I don't know if you all have this in your region, but there's an invasive plant called the kudzu vine. And the kudzu vine, I remember driving in the South with my wife and saying, "Oh, isn't that beautiful?" And she corrected me quickly and said, "No, that's actually an invasive plant that's going to kill the trees." So maybe not as beautiful if you think about it that way. So, but what I'm thinking about as far as a metaphor is concerned is I have an axe, and my axe is ERP. When I'm treating OCD, exposure plus response prevention. The question is, if I'm trying to chop down the OCD with this axe, can I access the trunk? So if I have the kudzu vine is so thick on that trunk, I can't get to the trunk, and I'm trying to cut down the tree, I'm going to need to take down the vines first. And so that becomes the metaphor for, and whenever I'm thinking about what am I going after first, my first question isn't so much which came first. Patient priority becomes a piece of it, but do I really think that I can get a good shot at this? And if the patient is so severely depressed they can't show up for their appointments because they miss, because they're sleeping in, because they didn't sleep all night, then my answer probably is going to be I better do something about the depression first. Or in the case of suicidality, they have enough suicidality that makes me worry about stressing them out using ERP. Maybe I need to deal with that before I swing the axe, the ERP axe, at the trunk of OCD. That's kind of the idea I have. And it's very visual in my head. That's the first thing I'm doing. Okay, next one. So when it comes to considerations for treatment, you've got OCD, exposure plus response prevention, ERP, is one of the ways we would do that. We just jumped ahead a little bit. That's okay. And behavioral activation would be a very well supported intervention for the treatment of depression, and you can incorporate elements of both. I would say I'm really going to try to focus my intervention on one, and keep an eye on the other if once I make my decision of whether I pass through here. Okay. A long paper and a very important paper, 1986. Emotional processing of fear, exposure to corrective information. This is Foe and Kozak. And I think that this is really getting to the heart of the matter, which is in treating OCD, I'm actually looking to change their thinking, but I may well be best able to change their thinking by changing their behavior. So if I have you lean into the fear, and I have you reduce and ultimately eliminate your compulsions and avoidances, you're going to learn something that you couldn't learn otherwise. You're going to learn that maybe these bad things don't happen. You're going to learn that the intrusive things that you're afraid of don't occur. And you're going to start to build some confidence and some faith that maybe these thoughts don't mean that I'm a killer. Maybe these thoughts don't mean that I'm going to harm my baby. Maybe these thoughts don't mean I'm going to get a dreaded illness to my people. Okay? So that's I'd encourage you to go back through this paper. It's an important one. I'm going to summarize it more readily in the next slide. Actually, I'm going to talk a little bit. Yeah, there we go. Let's go to the next one. And so to me, a succinct explanation of how this treatment ERP works came from my then 6-year-old daughter, who actually turned 26 today. And she was upset with me having to go out to do a workshop for 3 days. I was going to be away for the weekend. And the big crime was I was going to miss her soccer game. This is 6-year-old youth soccer. She was playing like it was the World Cup final. Most other kids were just running around having fun. That's not the way that my kid works. And so she was mad at me. And she asked me a legitimate question, which is, are you telling me it's going to take you 3 days to teach people what you know, which was no compliment. And I'm very good at ignoring tone. I said, yeah, it's really complex. And she says, no, it isn't. If you told it to them in one sentence on Friday, you could finish and then you wouldn't miss my game. And now I got curious about what that sentence would be. But what sentence is that? And here's a 6-year-old basically summarizing her father's life work in one sentence. And I think that Rachel has done a very similar task here for the treatment of depression in BA. There are a lot of parallels between BA and ERP. And suffice it to say that we want you to go do things that you're either afraid of or unmotivated to do, because you will see that the more you do it, the easier it gets, and it starts to become easier to get yourself to do things, and then those things get easier to do, and you get on the better treadmill than the one you're on. Okay, next one. So I think we're here for the example, right? Mm-hmm. All right. You want to walk us through this, Rachel?
Sure. So I'll read through the case example, and then I think both of us can kind of talk through some strategies with a kind of example of a patient. So this is a 27-year-old female who has OCD characterized by intrusive thoughts about harming herself and corresponding avoidance of being alone, using sharp objects. And she's also frequently seeking reassurance from others that she won't act on these thoughts, that she doesn't want to harm herself, and engaging in some mental rituals such as reviewing her reasons for living. Her OCD symptoms have become increasingly impairing over time. And as a result, she started to experience more severity in terms of depressive symptoms that are really related to the impairment and distress experienced by the OCD. As this has progressed over time, more recently, she's been reporting increased hopelessness and at times even some suicidal ideation, which she finds very alarming. So she stated, maybe it would be easier to just kill myself rather than continue to live with this.
Okay. First thing I want, if this is somebody who's showing up at assessment, is I want pretty good, detailed evaluations of the OCD symptom severity and the depression symptom severity and the suicidality. So I can put all these things together. This is an example of a case, which is, again, the more common way you see this is OCD onset first, depression subsequent. And even with a patient overtly stating that my depression is because of the associated impairment and distress coming from the OCD, which sort of invites you to want to treat the OCD first, except that I want to know more about the level of suicidal ideation, the level of hopelessness, and whether or not she is experiencing a desire to die, and whether or not she has plans, and whether or not she has intent to act on those plans. So even though I see it seems like logically I'd want to go after the OCD because, again, if I can reduce the OCD, you may see improvements in that functional impairment. You may see improvements in depression. The data would suggest both in outpatient and in residential that you do see about a 50% symptom reduction in depression when you treat OCD successfully. But I don't want to do that in a way that I'm not paying sufficient attention to the ideation. So I'm going to ask a lot of questions about that. I am going to ask her what I call the magic wand question. So if I could take out one of these things with a magic wand, which of those should I take? My guess from this presentation and from having seen lots of patients like this, they may well quickly say, well, the OCD, because it's causing everything else. Cool. All right. But now let's circle back to what that everything else is, especially around the depression. So then I would be looking to do what Rachel was suggesting, which is a careful assessment of risk and then possible safety planning before I proceeded with anything else.
And I think I'd want to know too, with that statement at the end, so maybe it would just be easier to kill myself than live like this further. Well, what happened next? Was that one fleeting thought that you responded to at that point with anxiety? Like, oh my gosh, would I ever actually do this? And then it kind of was triggering the OCD, even though in that second it was a kind of a wanted thought. Or did they start to think through, how would I do it? Do they have a specific method or plan identified? What is the degree of intent? What other risk factors do they have? And I think that might also tell us more about how to proceed with their treatment moving forward.
Yeah. And with respect to the intrusions about self-harm, I'm also interested in, does she have intrusions about using those same implements to harm other people? Because there may be a hierarchy there. So it might be that the intrusions about harming other people are less anxiety provoking than the ones about self-harm, in which case I can begin a process of creating a hierarchy of intrusive thoughts pertaining to self-harm. And oftentimes I will do that. I'll have people bring relatively sharp knives, more sharp knives, fish boning knives to the session. And I'll put myself in as the person who's going to be the object of such things. Have them sitting in my presence, having the intrusive thoughts about cutting me. I'll stick my arm out without looking at it and have her hold the thing to my arm and have her have the thoughts and have her see that, hey, wait a minute, just because I'm having these thoughts doesn't mean I'm going to do it. Doesn't even mean I want to do it. So I might get some habituation with that, which then might set the stage for me to have, okay, so if that's how it works with these thoughts, I wonder if it's the same thing with the other kinds of thoughts. Can we use some exposure techniques to help you with that? So being in the presence of these things, being in the presence of content that prompts thinking about suicide. And then I can carefully monitor what's happening, not only with the level of anxiety around that, but what's happening with the suicidality. I also think that hopelessness piece, you might be able to do some psychoed around that, because the hopelessness might be coming from, and this is going to go on forever. And my response to that is, well, that's certainly a hypothesis, but the data that we have for the last 30 years would suggest otherwise. Let me show you some studies of folks who have OCD and depression. Let me show you some outcomes. Let me show you what we're seeing. Let me explain how this may work in you. And then I'm going to return to that hopelessness and say, it sounds to me like you were afraid this is going to go on indefinitely and no one could help you. Do you feel that now? Well, no, now that you explained it, it seems easier for me to be optimistic. Okay. And what are the implications of that for wanting to die? Well, I think if I could see an end to this, if I could see myself getting better control over this, then I think I'd be less inclined to feel like that's an out that I would consider. So, or it doesn't touch it. And if I try that intervention, it doesn't touch it, then I'm a little more inclined to move towards BA and DBT and safety planning and all those things that are in the repertoire for folks who are depressed before I step on the gas with ERP.
Yeah, and I think it's not clear here, but certainly if there's other OCD symptoms too that are not these, that might be a nice starting point. So if they have some contamination or ordering and symmetry concerns that are clearly kind of distinct, then that might be a nice way to start gradually working on OCD at the same time as targeting the depressive thoughts and the suicidal ideation. And then as that gets better, maybe kind of going up to more of those challenging OCD symptoms.
Yep, I think that's exactly right. And the way I think about OCD, I always think about OCD as being like the state of Hawaii, in that there's a big island and there are other islands that are smaller and nearby. Customarily, when I'm treating OCD, and every one of them can be broken down on a hierarchy from low, medium to high. Things that would provoke a little bit of this fear, some of this fear, and a lot of this fear. So every island can be broken down that way. I used to play Risk when I was a kid, so I visually see that map. And so I want to usually go after the island that's associated with the most functional impairment. Now, in this case, it might be that suicidal obsessions are the most functional impairment on an island, but there would be an argument to be made here that if I go after an ancillary island, a perfectionism island, or a scrupulosity island that's easier, maybe in this case, I'm gonna take a peripheral island first, get my flag on that island, show her how this treatment will proceed, and turn back to the other. I'm customarily going after the big one first because you get generalization down a hierarchy, typically not up. So if I could take the big island, sometimes I turn back to the little ones and my flag is already up on. And that's fabulous because the patients learn how to do this. I'm a little cautious if the patient's telling me that they can't differentiate suicidal obsessions from thoughts about suicide. I'm a little more inclined to do what Rachel said. And what do we say? We try the perfectionism stuff first and see how that goes. And I'll test the waters and I'll see. And the whole time I'm giving regular assessments, both formal and informal, about what's happening with their symptoms and also what's happening to their sense of hopelessness that we can't do anything about this. And I tell people all the time that no, the bad news is you got a condition here that is impairing and associated with a lot of difficulty. The good news, if it's OCD, is we know what to do. Like we have enough data from the last 40 years of randomized controlled trials. I can make a reasonable estimate that if you finish this treatment and do it the way that I'm suggesting, the vast majority of folks who do that experience significant symptom reduction and maintenance of gain. So there's reason to be hopeful. We have to be, obviously the caveat I put in there was we have to do it the right way. And we have to complete the treatment. Can't just start it and expect it's going to be fine. If I give you antibiotics and you take 3 days of them and not 10, you're not going to get the same outcome as you would if you took 10. So I want to be paying attention to the patient's mindset. But I do think in this case, what Rachel raises is an excellent point. If I took on something OCD-like that wasn't this overlapping content, I might be able to get some traction there. And patients will say, no, I have to do this one first. It's the biggest, most impairing, in which case they're going to talk me back to Big Island. But I'm going to be flexible in my approach while being mindful of not asking to do something that they can't do without raising the risk of suicide. And I think that's overarching forest level comment is I'm going to say that we need to do with all these folks. If I'm going to treat you using ERP, that's certainly possible. We've seen it. The data suggests that it will work, but we have to be mindful of these pieces so that we're not increasing risk and maybe making a problem worse that we should be attending to instead. Okay.
All right. And then I think we are on time for our question and answer section.
That was very perfectly timed out of all of the webinars. I think we're just at 1:15 Central, so thank you. Now it's time to answer your questions. We've had so many great ones come through. If you do have a question, please use the Q&A button, not the chat feature on the Zoom taskbar. We'll try to answer as many as we can in the time we have left. But if we don't get to your question, please send me an email message afterwards and I will follow up with you. Okay, it looks like the first question is, are there common medications used that you see when treating folks that struggle with OCD and depression?
I'll field that one, yes. And what I'd say is if I have somebody, I mean, the SSRIs are FDA approved for depression. Some of the SSRIs are also FDA approved for OCD. So what I'd say is if I've got somebody I know has both, my inclination would be to use one of the SSRIs that's been approved for both. And you know, the mechanism by which those things are reducing both obsessions and depression is not well understood, but the data would suggest that with these medications, I'm likely to get two birds with one stone, or at least mitigate the symptoms some. Partial symptom reduction is the norm with med, but I would say that if I had somebody who had both, I'd be inclined towards those FDA indicated antidepressants for OCD. That'd be the first thing I would be looking at.
Thank you. The next question is, does exposure to violent images or trauma impact visual imagery, unwanted thoughts with someone who has OCD?
I think that's a complex question. And I think that certainly we do a ton of exposure to hypothetical, unwanted, intrusive images of violence. We do it all the time. If it's violence that had been experienced, and that implies the traumatic piece of this, there are treatments for violent symptoms related to experience of violence, one called prolonged exposure, which we would be using in that case, but I think that they'd be handled a little bit differently. So if I have somebody who has intrusive, unwanted thoughts about violence, they have no history of being assaulted, they have no history of assaulting anybody, then I would do ERP the way I would anyway. But if I have somebody who has a history of traumatic, violent experiences, I want to know, are the intrusions you're getting, you know, quote unquote, are they related to that past event, or are they separate from that past event? If they're related to the past event, then I'm going to shift a little bit towards treating the traumatic element of that, using prolonged exposure as opposed to exposure plus response prevention, which is not really designed to help you process the trauma, because in theory, you haven't experienced the trauma. You're having intrusive thoughts as opposed to trying to process something that actually happened to you. They're very different things, very different interventions, and you need to make some of the same decisions there that you make about treatment of depression in OCD. Which is primary, which is causing the most functional impairment, and can I swing this axe? I mean, there are some people I've treated for OCD where they had a traumatic background, they had a traumatic experience, and sometimes the trauma precipitated the severity of their OCD, but they're separate enough, I can still do the ERP treatment, but sometimes they're so intertwined, I have to go after the trauma using prolonged exposure, and it's really quite a different intervention.
Thank you, Dr. Franklin. The next question is, are there any suicide risk tools that have been developed specifically for use or to facilitate reliable, quick differentiation among individuals who also experience OCD?
That's a tough question. I don't know of a specific tool that will help differentiate between the thoughts that might be kind of OCD versus more suicidal in nature. But I think in terms of risk assessment, there are a number of tools out there. I'd have to kind of look up the age ranges for them. But I know that I believe the CAMS is something that we've used more with kids. I'd have to see though. I don't know if you know offhand, Dr. Franklin, the lower age limit on the CSSRS, the CAMS, the safety.
I don't. But I think to circle back a little bit on that too. Well, I'll leave it at that.
I guess what I would say is the content would be the same. We'd want to assess a lot of those same areas, but then I think the way that you would ask the question would be different. And then, there's, I think, a point at which you'd have to decide if you're talking only with the child, with just the parent, or with both, and what that looks like.
Thank you. The next question is, couldn't misdiagnosing suicidal OCD and creating a safety plan increase the OCD symptoms? And the next part is, and isn't it likely that such clients would have a plan or method? For example, what if I swallow all the pills at once?
Yeah, I think that's a really good question. And that's where a good functional analysis comes in. And we certainly seen a fair number of our OCD patients who have suicidal obsessions wound up diagnosed on inpatient units with depression, because people don't know that distinction. You don't know OCD, and you don't know that intrusive images about suicide are an element of OCD or a subtype of OCD, then you might just assume that thinking about suicide must mean you're depressed and must mean you need to be housed away. So I agree. If you miss that boat and you're telling somebody that they are at risk for suicide because they're having thoughts about suicide, and yet those thoughts are intrusive, I think you'd be doing a disservice. So a good functional analysis, just the way we described, would help us with that. And I wouldn't want to do safety planning for somebody who's not objectively in any sort of risk for that. And I'd want to do a lot of psychoeducation around that. People may not understand this distinction. Your clinician may not understand this distinction. Let me explain what the distinction is so you can make it. So you know the difference between an unwanted intrusive thought associated with anxiety, which is under the OCD umbrella, versus a thought about ending your own life that seems convergent with your mood and you're moving towards action. And that's under the depression umbrella. So I want to make sure they can learn. Because unfortunately, I think there's sometimes, and we see this in schools too. You tell somebody that you're having unwanted thoughts about killing yourself, and they're going to call your mom and have you get picked up, because they don't want to take the risk that you might hurt yourself. But if you have OCD, then my guess is you're not at high risk for harming yourself in response to those thoughts specifically, and we're reacting to these thoughts as if they're emanating from depression and suicidality when they're actually not. So I've got to teach people around these kids too what is and what isn't. And parents, I start there too. If you tell your mom you're having unwanted, or you're having thoughts about killing yourself, my guess is your mom's gonna get your mom's attention. And if she doesn't understand that distinction, she could also make the same error in judgment to treat it as if it's suicidal thinking or ideation as opposed to an obsession. It's not common knowledge, which is why I think it's so important for us to disseminate this information to clinicians, because you miss this one and you might wind up putting somebody on a path that's not the path they should be on. I agree with that.
Thank you. Our next question is, can OCD treatment work with someone with pediatric autoimmune strep and brain pandas?
Rachel, you want me to handle that one?
I mean, I can start us out and just say that, I think there might be other components of intervention there, but exposure and response prevention is generally recommended as well as a primary intervention to handle the OCD symptoms.
Yep. Eric Storch did a paper maybe 15 years ago looking at 15 consecutive pandas cases, and everybody got ERP I think almost everybody got an SSRI. Some people got something to treat the infection, antibiotics, and it looked like folks tolerated that just fine. What I'd say is something that Michael Kozak used to tell me all the time, which is the factors associated with etiology may or may not be the factors associated with maintenance. And CBT for OCD is a maintenance-focused treatment. So in other words, I'm not so interested in why you have OCD. Like some people's their backstory involves, well, we went on a camping trip and she got really scared when she was 5, or she had an infection, or whatever the case may be. Like, I'm not there. I'm here. So this is 11 years later, and lo and behold, if you had an infection and you had it treated, good for you. Now you have residual symptoms. We should deal with them using the methods that we know are effective and have been demonstrated consistently to be effective. So I'm not inclined to think about PANDAS as anything other than another way that people can wind up with OCD. And the reality is that it's a fuzzy diagnosis, and I don't know if there's a definitive test. I think it's a little fuzzier than that still. Certainly, strep titers will tell you something about whether you have strep infection, but whether it says anything about causality is another matter. But what I would say is I'd be interested in that case if I have that kind of complex presentation and the quintessential sawtooth pattern of up when you get infected and down when you're not, and up again when you get infected again. If I'm seeing that, then I'm inclined to say let's treat the OCD using ERP and possibly an SSRI, and let's treat the infection separately and render unto Caesar what is Caesar. Okay.
Thank you so much, Dr. Franklin and Dr. Leonard. That's about all the time we have today for questions. If I didn't get to your question, please feel free to send an email to webinars@rogersbh.org. Many thanks to our presenters for taking time away from their clinical practice to share your valuable insights with us today. Helping a patient on the road to recovery means collaboration among everyone involved in their treatment. With locations across the country, our treatment teams are ready to partner with you. Rogers Outreach representatives are happy to answer questions regarding our treatment services, as well as learn more about your practice. Before we conclude, I'd like to ask our presenters to share a few key take-home messages from today's presentation.
Well, I think we wanted to just share a couple of resources as well. So here are 2 organizations that have a lot of really helpful information. There are blogs and newsletters. So one is the International OCD Foundation, or IOCDF.org. The other is the Anxiety and Depression Association of America, or ADAA.org. And then in terms of kind of a recap, I think, these are kind of complex differentiations to make, but coming at it from a really careful assessment of the nature of the OCD symptoms and that functional analysis that Dr. Franklin discussed, understanding some of those key factors of depression, including the presence or absence of suicidal ideation that's more mood related, and a careful assessment of suicide risk are all going to be important parts of that formulation that will then help you determine kind of what those next steps are to make. So thank you all for joining us today.
Thank you, Dr. Leonard. And that about wraps it up, everyone. I just want to remind our participants that those of you who've met the required time commitment will be eligible for CE credits. About 30 minutes after the webinar ends, you'll receive an email with a link to your personal dashboard on ce-go.com, where you will be able to access PDFs of the PowerPoint presentation, slides, handout, and a complete list of references. Those of you who met the time requirement to qualify for CE credits will need to complete the evaluation to download your CE certificate for the event. If you have any questions about this follow-up email, please contact support@ce-go.com. On behalf of everyone at Rogers, we look forward to partnering with you to help support your patients. Thank you.